I'm Sarah and I'm a paramedic with Ambulance Victoria. For the sake of today's scenario, we'll be operating under Ambulance Victoria's clinical practice guidelines and we'll be conducting scenario 1. The page that we've received as a MICA unit is that we're going to a 62-year-old male in cardiac arrest. We've received a sit rep from the ALS crew on scene that they have just got ROSC. As we've arrived on scene, we have our PPE on. We're conducting our dynamic risk assessment and we've been assessing for dangers, looking for obstacles and hazards, as well as considering what access and egress issues we might have. So we're now going to enter the room. Hi guys, I'm Sarah and this is Mike.
Hi guys, my name's Michaela, this is Vicky. This is Bill. It's a 62-year-old male who was found unresponsive on the couch by his friend. He was then lowered to the ground where bystander CPR was commenced. When we arrived, he was found to be VF arrest. We've delivered 2 shocks and we've just placed an IV in. And just as he walked into the room, he has got ROSC.
Yep, excellent. Sounds like you guys have done a fantastic job. So what we'll do, we'll just go straight back to our primary survey. So while I'm doing that, Michaela, can I just get you to confirm that that IV is patent? Yep. So, Bill, can you hear me? I'm not getting a response from Bill. So now, Vicky, when you slotted that LMA, how was the airway when you initially assessed it?
The airway was good, it was clear, so we didn't need to suction or anything.
Yep.
He's bagging well, but I don't feel he's tolerating the Agile really good.
Yep, no, that's all right. So we're going to get that addressed immediately. So, Mike, can I get you to take over on the airway? I'd like you to try and ramp that position up a little bit more, get it more optimised. Can I get you to pull the LMA out, reassess the airway, and we'll go back to bag valve mask ventilation and try and optimise our preparation of this patient. I'd like you to aim for 12 breaths per minute, looking for rise and fall of the chest, and we'd like the end tidal between 30 and 40 if we can target for that. Now, Vicky, what I'd like you to do, can I get you to come to this side of the patient for me, please? Sure. And what I would like you to do is I'd like 2-minute obs called out from the monitor. Can you also do a 12 lead, a BSL and a temperature? Once you have those, can you get my attention and let me know what those values are? So I can presume that since Bill was found and his friend has now left the room, so we have no way of being able to tell if he has any allergies, we have no medical history, and we have no medications that I can see, and there's no way of telling when his last meal was. So we'll operate with the presumption he has no allergies. Michaela, what I'm going to get you to do, can I get you to draw up 2 1mg adrenalines in a 3ml syringe in case we go back to a re-arrest?
Yep.
I'd also like you to prepare a 1 in 10,000 adrenaline. Yep. And I'd like you to start an adrenaline infusion. Do you know how to do that?
Yes, I do.
Yep. So just to confirm, I'd like 3 milligrams of adrenaline with 47 mils normal saline drawn up to a 50 ml syringe. Yep. Once you have that ready, can you get my attention and I'll tell you what to commence it at. Perfect. I'm going to continue with assessing the patient. So I'm going to start with a very thorough GCS. So starting with the eyes, we don't appear to have any spontaneous eye movement. Checking for response to voice and pain. Bill, can you open your eyes? I'm not getting any response, so we have an eyes of 1. We have no voluntary speech, so I can't ascertain whether we have spontaneous, confused, inappropriate, and we have no sound. So we're going to go with a 1 for speech as well. Moving straight through to motor. Bill, can you squeeze my hands? Not getting a response to that. I'm going to apply bilateral nail bed pressures, and I'm noticing that I'm getting extension. So that's a 2, so we have a complete GCS of 4. I'm going to move straight through to my respiratory assessment. So we have skin that is cool, pale and dry. We have an unconscious state and a heart rate of 130. Our appearance is consistent with being unconscious. We have no speech to ascertain. We have a rhythm and effort that is consistent with being ventilated, no spontaneous efforts. We have a rate of 12, which is being assist ventilated, and I'm going to auscultate for sounds. So I'm listening for any crackles or wheezes or other adventitious sounds. I'm not detecting any adventitious sounds there. So moving straight through to confusion status, I've already covered skin being cool, pale and dry and our patient being unconscious. Heart rate is 130. Can I get you to hit the blood pressure button on that monitor for me there, Vicky? I'll just give you some assistance there. It's just that button there. Sorry, thank you. No, that's okay. Alrighty, how'd you go with the 12 lead? Yep. Alrighty, so while I'm assessing the 12 leads, so we have P waves that are consistent and preceding each QRS, a PR interval of less than 2, QRS complexes appear to be consistent and less than 0.12. I'm not noting any ST elevation or depression, there's no ectopics, and I believe this 12 lead is consistent with the sinus tachycardia of 130, which reflects what I'm seeing on the monitor. How'd we go with our temp and BSL?
Just in the process of getting that for you.
Yep, not a problem. How are we finding the airway there, Mike?
The guys are correct. There is some resistance, but I'm managing to ventilate. No worries.
Yep, not a problem. So we're not recounting that resistance
No,
anymore.
not the resistance from that.
No, excellent. Okay, so we'll just make sure we want to have a peak. We'll start with a peak of 2.5 just because we have had a little bit of resistance and we can dial that up as appropriate. Our end title's now down to 35. So that's consistent and working, operating well. How are we going with our medications
Yeah,
over
very
here?
good. Both of the adrenalines have been drawn up, and this I'm just doing the adrenaline infusion now.
Yep, so that blood pressure's just come back. So we have a blood pressure of 88 on 57. My concerns for this patient initially are that we have a GCS of 4 with an unprotected airway and we're hypoperfused. So we're going to need to manage that with some bolus adrenaline as well as getting that infusion ready. So
BGL we've got 6.8
Yep.
and temperature's 36.3.
Yep, excellent. So we're going to need to be mindful of considering our exposure with this patient. What I'd like you to do now, Vicky, is can you take over on the airwave there for Mike? So just continuing to ventilate with 12 breaths per minute, that rise and fall of the chest that we're looking for, and targeting the end tidal to between 30 and 40. Mike, I'd like you to come over here and start managing the perfusion. I'd like 100 mics of IV adrenaline given as a bolus.
Yep.
Once we have the infusion ready, we're going to start that at 20 mics a minute. Can you just confirm those back to me?
I can, yes.
Alright. How are you going with the infusion?
Very good. It's almost all completed.
Yep, excellent. So I'm going to continue with the secondary survey. Once we have that infusion ready, I'm going to get you to jump to the other side of the patient.
Yep.
I'd like a second IV placed.
Yep.
We're going to start preparing for RSI as I feel we're going to need to protect this patient's airway. So once you have a patent second IV, I'd like pre-hydration of 10 mils per kilo.
Yep.
I think Bill weighs 80 kilograms, so we'll aim for 800 mils.
Perfect.
And I would like that given with a pressure bag. Vicky, can I get you to please put nasal cannula in and run that at 15 litres a minute so we can get our pre-oxygenation happening for this patient as well? I'm going to start with my secondary survey.
100 mics of adrenaline burning.
Yep, excellent. Thank you, Mike.
Just about to start this.
And Vicky, I'll get you just to continue with reading out 2-minutely obs for me once you've got
just
that
about
established
to
as
do
well.
one for you.
So just starting with the pupils, checking bilaterally. They appear to be responsive and equal with a size of approximately 5. I'll just hit silence on that one. Alrighty, so just checking the head, feeling for any boggy masses or hematomas, checking my gloves for blood, feeling down the neck, not feeling any crepitus, neck veins appear flat, there's no tracheal deviation, checking through the shoulders and feeling down the arms, feeling for any deformity, any contusions, looking for bruising, rashes and angioedema, still continually checking for blood, feeling across the chest, there's no crepitus, chest appears to be expanding with equal expansion consistent with each ventilation.
Blood pressure 91 on 56.
Yep, excellent. So we are getting a response to our adrenaline in Mike, but I think we need to give some more. So what I'd like is another 100 mic bolus of the IV adrenaline. And once we have the infusion, we'll get that started at 20 mics per minute. Let me know when that's established.
Okay, another 100 mics now.
Yep, excellent. Alright, just going to feel through the abdomen. Appears to be soft. I'm not getting any rigidity. Can't ascertain for tenderness. Checking the pelvis. Feeling down the legs, still checking for deformities, not feeling any deformity or crepitus, there's no bleeding. I'm going to slide up my hands underneath the patient to try and check the prone side, not feeling any deformity, there's no boggy masses there, still checking for blood and I'm noting that there is none. So I'm happy that we haven't revealed anything else in our secondary survey. How are we going with the airway there, Vicky?
Airway's good.
Yep, excellent. How are we going there, Mike?
The adrenaline infusion is on.
Yep, excellent. So we've got that started at 20 mics per minute. Can I confirm?
Yes,
Yep.
20
Can I
mics.
get another blood pressure done there? Can you just hit the button for me there, Michaela?
Thank
Yep. Right, so happy with our ventilations at the moment. And we're getting our RSI preparations underway. So once we've got that second line established, we'll continue with the pre-hydration. Now, I think we need to start getting our RSI medications ready. So what we're going to proceed with, Mike, is we're going to go with a fentanyl and succinylsodium preparation. Are you happy with proceeding with that?
Yes.
Yep, so what I would like you to prepare for me is I think we will give 100 mics of IV adrenaline. So I'd like 100 mics drawn up to 10 mils in a 10 mil syringe. When we get to administering that medication, the entire amount needs to be given.
Yep.
So there'll be 100 mics of fentanyl, confirming.
Yes.
We're also going to administer our succinylsodium, which is 1.5 milligrams per kilogram.
Yep.
So
blood pressure's 110/59.
Excellent. So we've got good management of our perfusion now. So once we drop every medication, I'd like each of the syringes labelled.
Yes.
So 1.5 milligrams per kilogram would be 120 milligrams, but with suxamethonium we need to round to the nearest 25, so we'll be giving
Shots out.
125 milligrams. Thank you, Michaela. So I'd like 100 milligrams in one syringe and 25 milligrams in the other syringe. I'd also like 600 micrograms of atropine in a 1 ml syringe in case we encounter any bradycardic incidents.
Okay.
Once we've got that prepared, we're also going to continue with our post-intubation sedation and paralysis. So we're going to need our rocuronium 50 milligrams. I'd like that to the side but not drawn up at this stage. And we'll get Michaela working on the post-intubation sedation. Are you happy with the fentanyl and the midazolam infusion, Mike, once we've got that ready?
Yes.
Yep, excellent. I'd also like you to start preparing our RSI equipment once you're ready on a nice clean pillow slip for me.
Shots away.
Excellent. Alright, so we're happy with our ventilation, so we're getting that pre-oxygenation on board, our patients adequately ramped and prepared. We've got our pre-hydration happening as well. Working through our medications, everyone's happy with our plan, so at this stage we've got our hyperperfusion appears to be adequately managed. We're going to repeat our GCS nice and thoroughly, so once we get to the point of commencing the RSI, I will come up to where you are, Vicky, and I will take over the airway. At that stage I'll get you to move to where Michaela is. Your job will be to continue to call out 2-minutely obs for me, get my attention with each one and make sure that you confirm that I have heard you and I repeat those back to you. Michaela's job will be to come and administer the RSI medications once we get to that stage.
Yep.
And Mike and I will get you prepared on what you need to give any mod order.
Yep.
Mike will come and assist me with the airway. He'll be the airway assistant handing me everything that I need during the time. I'll be placing the tube. Once we have confirmed that we have appropriate tube placement, then we'll look at working on our extrication, which I'll probably designate to you, Vicky, as well as providing a sit rep to the receiving hospital since we don't have any air support.
New blood pressure of 105/59.
Yep.
Pulse rate 134.
So we'll keep the adrenaline infusion going at 20 mics per minute at this stage. I feel that we're getting adequate support with that and we don't need to consider any further fluid administration other than our prehydration. So I've planned with the airway, Mike, I think we're going to proceed with the bougie attempt first.
Yep.
So I'll place the bougie. Once I confirm that I visualise that through the cords and it's adequately placed, I'll get you to slide the tube over for me. Once I've confirmed I have hold of the tube, then I'm going to get you to very slowly feed the bougie out once the tube is correctly placed. Vicky will then connect the mask, bag of mask for me and we'll confirm our placement. Provided our placement is confirmed, I'll get you to auscultate the chest. We're going to tie that off. I'll then get you to assume control of the tube, making sure that someone always has hold of and is in control of the tube at all times.
Yep.
And I'll place the orogastric. So failing our first attempt, we will have a second size tube, one size smaller, prepared with a video laryngoscope. That will be our plan B approach. Failing that, we will then have our LMA prepared and ready to go in our failed airway algorithm, and we'll have a crite kit ready as well, which I'll get you to confirm the crite membrane with me when we get to that stage. Is everyone happy with their roles at the moment?
Yes.
Yes.
Excellent. We'll go through this again and we'll make sure that we go through our RSI checklist when we get to the time. So we've got that pre-hydration now deciding to go.
Yeah.
Yep, excellent. I'll get you to pop that one up to the side for me then, Michaela, and we'll get our post-intubation sedation prepared.
I haven't started the Madaz fentanyl.
No, that's fine. So we've got all of our other medications ready. I'm just going to do a check. We have our fentanyl, 100 mics prepared at 10 mils. We have suxamethonium, 100 milligrams in one syringe, and we have 25 milligrams prepared in the other. We have 600 mics of atropine in a 1 ml syringe. We also have our fentanyl Madaz preparation ready for our post-intubation sedation, and we've got our rocuronium set to the side as well. Are you happy to proceed with our post-intubation sedation infusion?
Can I get a recap of what we need to do again?
Absolutely. So what we're going to do is a fentanyl midazolam infusion. So
Yep.
I'll get you to check these drugs off with me.
Yep.
So we have 300 mic and 2 ml fentanyls.
Yep.
So we'll need the whole 300 mics drawn up.
Yep.
We have two 15 milligram in 3 ml midazolams.
Yep.
The whole amount of those will be drawn up as well.
Yep.
You're going to dilute that with 18 mils of normal saline, which
Yep.
will give you a total of 30 milligrams of midazolam and 300 mics of fentanyl
Yep.
in 30 mils.
Perfect.
Each mil that we administer will contain 10 mics of fentanyl and 1 milligram of midazolam. When I tell you to start that infusion, it's going to be commenced at, we can start at anywhere from 1 to 10 mils an hour. We'll start at 5 and we can dial it up as we need. So we'll be continually monitoring for signs of underparalysis, looking for any trends in heart rate and blood pressure, any movement, any gagging, anything. Will also prompt us with our paralysis.
New
Are you happy to
BP.
get that ready?
105 and 57, ETCO2 33, a heart rate of 134, SpO2 sitting at 93.
So we still have a tachycardic patient. We're now reached a point of normotension, which is being maintained with our adrenaline infusion. We have normocapnia occurring. I'm happy with our 12 breaths per minute. Our SpO2 can be optimised a little bit more and can be a little bit higher. We'll make sure that we have that adequately under control when we get to preparing for the RSI. So, Mike, how's the equipment setup going there?
We're just about done.
Excellent. I'm going to move to where you are, Vicky, and I'm going to take over control of the airway, at which point I'll get you to move to a point where you can do continual call out of the 2-minute odds. I'll also get you to apply a blanket to our patient. We're in a nice warm room and a nice warm day, but we just want to make sure we're not losing any temperature with our patient there. So I'm just going to step behind you there, Michaela. So stepping behind, and I have control of the airway. I'll relieve you there, Vicky. Alright, now Mike, I'll get you to just dial our peak up to 5 there for me and just confirm that it is at 5. Excellent. Alright, so we've got our laryngoscope and our video laryngoscope prepared there. Alright, how are we going with our infusions over there, Michaela?
Yeah, good. Just trying to get some normal saline to fill up the rest of this infusion.
Not a problem. Let me know when you've got that ready.
No worries.
Thank you for that there, Vicky. Alright, we have our RSI checklist out. Once we've got everybody in a good position, we're going to start that. You've got your stethoscope prepared, Mike?
Yes.
Excellent. So you're happy with how we're going to proceed with our bougie attempt first? So once we've removed the bag valve mask, I'll place the bougie. I'll then instruct you to start feeding the tube over the top. Once I've got hold of it, I'll instruct you to slowly remove the tube. And once I have the tube visualised and we've got confirmed placement, I'll get you to auscultate the chest and the epigastrium for me to ensure we have no issues there. Positive confirmation of the tube with our end tidal, I'll get you to tie off the tube for me. Or they'll get you to assume control of the airway while I place the orogastric. Are you happy with that plan?
Yes.
Excellent. Alright, can I get another set of obs there, Vicky?
Just doing that now for you.
Excellent.
So SpO2 is at 98%, ETCO2 is at 33. We have a pulse of 137 and just waiting on a blood pressure.
No problem. So still tachycardic, our stats have come up to a much better range. We're sitting between 97 and 99, still normocapnic, still got our risk rate of 12, and we're just waiting on our
blood pressure is 108 and 61.
So the adrenaline's holding our patient in a normotensive way. So we're going to redo our GCS at this point, so in preparation for our RSI. So our eyes, we still have no spontaneous eye movements. Bill, can you open your eyes for me? Can I just get you to give a slight squeeze to the shoulder there? No response to pain, so our eyes are a 1. Bill still has spontaneous verbal responses, so we can't ascertain any sort of confusion or agitation or orientation. We have no sound, so he gets a 1 for verbal. Bill, can you reach up and grab Mike's hands for me? Not getting any obeying of commands. Can I get you to apply bilateral nail bed pressures for me there, Mike? And we still have extension, so we still have a GCS of 4. And we've got that sedation prepared. Excellent. We'll keep it on that side of the patient, and I'll get you to hook that one up, Vicky, and we'll get Michaela around to the other side of the patient so that we can start getting ready for the RSI. Alright. I'll get you to hand the RSI checklist to Vicky.
5?
Yep.
Alrighty.
As soon as you've done that, Vic, I'll hand you this list.
So you just want it here? Okay.
And Michaela, those are all drawn up to give, so you
Yep.
give the full dose of all
Yep.
of it.
We'll run through the medications while we're just waiting on that one. So when we instruct you to give the fentanyl, we're giving 100 mics of fentanyl, which is drawn up to 10 mils. You'll give that as a straight flush. You'll then proceed to follow that immediately with the succinylcholine. So there's 125 milligrams across 2 syringes there, 100 milligrams in one and 25 in the other. They'll be given in quick succession. We'll then wait a minute for our signs of fasciculation and loss of jaw tone. Once we've got that and we've lost our end tidal, then we're going to proceed with the RSI. The atropine 600 mics is set up to the side there, so should we encounter any bradycardia at any stage, I will instruct you to give that.
Yep.
Are you happy with your role there so far? Excellent.
Yes.
Okay, we're
Alright,
running.
thanks Vic. So we're going to give you the, that shouldn't be running at this stage, let's make sure that that's
Sorry,
turned off,
yep.
because that's post-intubation
I started,
sedation.
sorry.
Yep, alright, we're going to proceed with that RSI checklist. Can you read that out nice and clear for me there, Vicky?
Sure. So position optimised.
Yes,
C-spine considerations.
not applicable.
Pre-oxygenation, oxygen supply sufficient.
Yes,
BVM peak, 5 centimetres.
yes, confirmed.
Nasal prongs
Yes,
at 12 litres.
yes.
Pre-hydration, IV, IO excess,
Yes.
preferably by 2.
By 2, yes.
Normal saline, 10 ml per kilo.
Yes, administered.
Preparation, drugs and doses identified.
Yes, correct.
Standard and video laryngoscope or laryngoscope and blades by 2.
Yes, correct.
ETT, one smaller or one smaller, one bigger.
Yes, correct.
Introducer, stylet,
Yes,
bogey,
yes,
tube tie,
Yes.
and sleek. Suction, tested and functional.
yes,
Functional electronic capnograph,
yes,
OP airway.
yes,
Adult monitor mode.
yes,
SpO2 filter liquid stick colorimetric capnography.
yes,
And iGel and lube.
yes.
Cricoidothermy kit and location marked.
Yes, kit's present. Membrane is marked.
Okay, so confirm ETCO2 waveform
Yes.
and long-term paralysis,
Our recruiting is prepared.
infusion, sedation, perfusion management,
Yes, prepared.
NG, OG tube,
Yes.
and
prepared.
trials.
Yep, not applicable. Alright, so everybody's happy with their roles? Alright, so Michaela, I'm going to instruct you to now administer the fentanyl and the suxamethonium in quick succession for me there. Can we note the time when the suxamethonium goes in? So Vicky, you're on 2 minute odds. Continue to get my attention for those.
Okay, so
We'll note
that
the time once the
is
sux is in and we'll
the
allow for a minute.
fentanyl. And the sux is going in now. So this is the first light.
Yep.
And then the 25.
Yep, and time?
Time is 12 o'clock.
Yep, excellent. So we'll wait for our minute. So we're looking for fasciculations, loss of jaw tone, and we'll look for the loss of our end tidal as well.
Blood pressure 109 on 60.
Yep, so we've still got normal retention, still being maintained with 20 mics per minute of adrenaline. How's our time frame going there?
Looking good with 12:01.
Yep, excellent. So we've reached our minute. I'm noticing that we've lost our jaw tone. We're now going to proceed with the RSI. So I'm going to get you to disconnect the mask here, Vicky. Bring this scope. Sliding through. I can confirm visualisation of the chords. Can you pass me the bougie, please, Mike? Thank you. Have a grade 2 view. Bougie has visualised through the chords. I'm happy with that placement. Can you please pass the tube over now, Mike? Continue to hold the bougie until I let you know that I've got the tube. I've got the tube holding the bougie for me, and I'm visualising the ASS markings passing through the chords. I have hold of the tube. Can you please remove the bougie for me? And I'll get you to inflate the cuff. Can I have the bag valve mask attached to the tube, please? Just need that attached there. Yep, excellent. And removing the LMA, sorry, the laryngoscope. Alright, so we have misting of the tube, chest rise and fall, just waiting for our end tidal to come back on. We'll be looking for our confirmed wavelength there, as well as a positive reading. Not noticing any sounds or resistance, and tidal is kicking back in. We now have 3 consistent waveforms with an end tidal of 37. I'm happy that this is confirmed placement. Can you confirm that as well, please, Mike?
Confirm that, yes.
Yep, excellent. So at this stage, we'll tie off the tube.
Blood pressure 104 on 56.
Yep, happy that we've still got normal retention there. Still got tachycardia. We've got SATs of 99, end tidal of 37. I'll get you to start that post-intubation sedation now, please, Vicky, and we'll start that at 5 mils an hour. Alright, and can you get that rocuronium prepared? And we're going to give 50 milligrams of that, so that'll be the entire amount that's in front of you there, Michaela.
Yep.
If you can draw that up and administer it for me, please.
5 mils an hour.
Yes, please.
Yep.
Just let me know when they're started. We'll get another thorough set of obs, and once you've done that, Vicky, can I
Done.
get you to start working on our extrication?
Sure.
So I'll get you to jump out and go get the spine board and our stretcher prepared. Give a sit rep to the receiving hospital, and we'll start getting prepared
And
for
you're happy
blood
for the
pressure's
rock to
coming
be
through.
given?
Yes, please.
That's
So
5
50
mil.
milligrams, which is a whole 5 mils.
Yep.
Mike, I'll get you to take over the tube here, and I'm going to place the orogastric. If you can hold the tube, so there's someone needs
That's
to be
the
holding
rock
this at all
delivered.
times. Thank you very much for that, Michaela. I'm going to step behind you there, Mike.
1208.
1208, confirmed. Rock uranium on board. All right. Just going to measure our orogastric here, and I'll get you to tape this down when it's in there, Michaela, as well.
Yep.
So if you can get some tape ready. All right, I'm going to feed this down the side here. All right, we appear to be at the third marker. I'll get you just to tape that in there. And drawing back, positive confirmation of sonic contents. We'll get the bag attached. Orogastrics in situ. And we still have an end tidal of 38, still with a good waveform. Normal tension at 110 on 60s, tachycardic still at 130, SpO2 of 99. We've got our ventilation going at 12 breaths per minute, so our tidal volume of 6 to 7 mils per kilo. We've got our PEEP set to 5, and we're going to keep that end tidal between 30 and 40. So I'm happy with our preparation at this stage. We'll proceed with our extrication. Thanks, guys.